Welcome to Module 5 and Chapter 9 of the semester. So let's talk GI. We used to say that the brain was the control center of the body, but research is really telling us now that the GI system, or our gut, controls a lot, right? The gut microbiome affects the body from birth to death, controls the digestion of food, the immune system, the central nervous system, and a lot of other processes throughout the body. So with that, let's get into it and start to see the connections between systems. First, let's review some basic A&P of the GI system. This system consumes, digests, and eliminates food products. The system absorbs nutrients, water, and electrolytes required for activity or really for those cells to work. So the picture in this slide is the alimentary canal, and it's approximately 30 feet long in an adult human. We know digestion begins in the mouth with the salivary glands, travels down the esophagus, the food does, where it's then stored and then mixed in the stomach. And then it moves to the small intestine where nutrients and fluids are absorbed through the villi. It then moves to the large intestine where water is reabsorbed and that chyme, or that food product, changes into a fecal mass. That then travels through the large intestine into the rectum where it's stored until it is expelled through the anus. Any issues along this path, as well as with any GI organs like the pancreas or gallbladder or liver, could result in alterations of this system that affects functioning. Changes to the gut are expected as we age. So dentition issues like ill-fitting dentures, tooth loss or decay, and decreased saliva production can impair chewing in our older adults. A GERD is common due to decreased gastric motility and delayed emptying, and also decreased peristalsis. The liver decreases in size, reduces the blood flow, leading to drug metabolism issues. And then liver cells also slow their ability to regenerate as quickly. Metabolism slows and changes the absorption of lactose, calcium, and iron, which can make bones brittle and prone to pathological fractures. Enzyme production decreases, decreasing the ability to break down sugar. Finally, decreased anal sphincter tone is present at times, and that results in increased risk for constipation and incontinence in our older adults. Common to other systems, the old and the young are at risk for GI alterations. A family history and genetic mutations, particularly for H. pylori, typically will put clients at higher risk for alterations as well. A diet low in fiber or high in alcohol is a risk factor, along with the use of certain medications, particularly NSAIDs, and that puts the client at high risk for bleeding. We think of opioids that put the client at risk for constipation. Smoking increases the risk for GI-related issues as well. Obesity and lack of physical exercise increases the client's risk of any kind of GI disturbance, as does stress, and then chronic diseases like diabetes or CHF. Maybe even COPD. All right, let's talk about one of the more common issues with infancy, and that's pyloric stenosis. It is the most common cause of intestinal obstruction in infants. It is the narrowing of the pyloric sphincter at the end of the stomach, which makes it hard for the stomach to empty food into the small intestine. So if it's going to happen, it most likely will show by 3 weeks of life. Infants are at risk, particularly if they have a family history of the disorder, or erythromycin use in early infancy or through breast milk, and that seems to cause issues with relaxation of smooth muscle and that sphincter. The condition is going to manifest as a hard olive-shaped palpable mass in the abdomen, and the child typically will have projectile vomiting after each feed, but after the feed they're still hungry. So a very different kind of feeling than with like a stomach bug. Lots of burping, maybe failure to gain weight, and if not caught, it can lead to dehydration or electrolyte imbalances. GERD is a super common disorder that affects nearly 20 million adults in the US. And this is when we have a backup of chyme, or that acidic fluid containing partially digested foods that goes backward up into the esophagus rather than continuing to the small intestine. Those that already have gastric motility issues are at high risk here, and basically anyone that has a condition that increases that abdominal pressure. So the lower esophageal sphincter is more relaxed than normal, so it doesn't close properly, keeping that chyme or that fluid moving forward. Smoking, alcohol, spicy foods, or foods with caffeine, even carbonated beverages, and even some meds can alter that lower esophageal sphincter pressure. Clients are going to present with heartburn, maybe regurgitation of food, nausea, or even maybe just a dry cough, laryngitis and pharyngitis. So cough, sore throat, a loss of voice, or a hoarse voice. Some might even say they feel like they have a lump in their throat while swallowing. So we want to educate these clients on foods that increase their abdominal pressure, but also about staying upright after eating and not laying down to keep that chyme and acid moving forward. Peptic ulcer disease is a group of lesions in the stomach or duodenum that extend through the muscularis mucosa. It affects nearly 4.5 million people, and the most common risk factor is using NSAIDs or H. pylori infections. So I really should say it's the overuse of NSAIDs. So our older adults are at high risk here because of the risk for GERD. Ulcers developed ultimately due to an imbalance between protective and destructive forces, so like increased acid production or H. pylori. And we see three different types, and the first is a duodenal ulcer. These are 80% of all ulcers, with the average age of onset about 20 to 50 years old. These happen due to excessive gastric acid or H. pylori. Actually, most people are positive for H. pylori here with a duodenal ulcer. Signs and symptoms are epigastric pain that's relieved by eating. Gastric ulcers are more deadly because of the risk for gastric cancer from them. So the onset is later in life, and it's associated with NSAID use and H. pylori, but most of these ulcers are not positive for H. pylori. They say the onset is later as older adults take more ibuprofen or NSAIDs to help with arthritis pain. That is what increases that risk there. The pain with these ulcers are worse with eating. And then finally we have stress ulcers. These develop not from H. pylori, but in the presence of stress, typically from a major life stressor like burns, trauma, or sepsis. Our hospitalized clients, and these are most often in the stomach. Hepatitis, any kind of hepatitis is inflammation of the liver and can be caused by infections, typically viral, alcohol, medications, and autoimmune diseases like lupus, RA, and scleroderma. Some recover and others progress to complete liver failure. There's a really good table in your book, but this picture on the screen provides a little snapshot of the different types of the disease. Hep A is waterborne and spread through fecal-oral route. Hep B is bloodborne and can be spread through sexual contact, mother to baby, or sharing needles, so typically blood and semen. Hep C is typically contracted through unsafe transfusions or sharing needles. Those with hepatitis D are typically dually infected with hepatitis B. And type D causes the most mortality. Hep E is also waterborne. Type A is an acute disease, and with treatment, it really clears, right? Type A. B, C, and D, and E are all chronic. So then we have fulminant hepatitis, and that's an acute onset and develops into liver failure or even death within 2 weeks. That is a quick overview of the GI system and kind of what is on your study guide. So that's kind of how I went. I've posted some videos this week. The first one, the gut and the brain, super interesting, about inflammatory bowel disease, and then disorders of the liver and pancreas. And then assignments to complete. Start working on your case study. That one is on diabetes. Accountability team 2, start thinking about that. Just meeting, talking about what's going on in your lives and how you're doing. And then keep thinking about your teaching plan, right? Looking at something at the bedside or in the community, in your clinic, wherever you're working, something that you can teach a client. So if you need help with that or have any, need suggestions or help, please let me know and we can meet up. Have a great week.